as soon as it's good to go.
Yeah. Yes, I start.
Yep.
Welcome to the IPA webinar series. It is our pleasure to present to you on behalf of the International Psychogeriatric Association this new webinar, and it's a webinar actually you asked for. And you asked for a webinar on novel drug therapies in Alzheimer's and other dementia. My name is Myrra Vernooij-Dassen. I am affiliated to the Radboud University in Nijmegen, and I have the pleasure to chair this webinar series. We are very happy that we can introduce to you two well-known experts in the field. And the first expert is Stephen Salloway. He is a medical doctor, and he is the founding director of the Memory Aging Program at Butler Hospital, Rhode Island. And he's a Martin Zucker Professor of Psychiatry and Human Behavior. He also is a professor of neurology at the Warren Allport Medical School, Brown University in the United States. And he will dedicate his talk on the current drugs and the drugs that are in the pipeline. The other presenter is Professor Edo Richard. He is a professor of neurology at Radboud University Medical Center in Nijmegen and at the Department of Public and Occupational Health at Amsterdam University Medical Center, both in the Netherlands. And his research focuses on prevention of dementia from a population perspective. And he has a line of research on ethical issues in prevention and early diagnosis. He is experienced in performing large investigator-initiated randomized controlled trial. And I want to state that both of our speakers are practicing neurologists. So they are not only scientists, but they are aware of the the IPA is dedicated to the mental health of older people, and it's world-leading multidisciplinary psychogeriatric association. So all these webinars are on behalf of IPA, and we work together in a committee, the webinar committee, with Professor Maria Lapid from the Mayo Clinic and Dr. Rob Maiden from Baycrest in Canada. And I have several household messages for this meeting, and in the next slides, and these are really very important because we want to make it into an interactive meeting, and therefore we use a chat box. You can use a chat box to ask your questions, and then I will read the question, and if necessary, I select the questions, and the questions which are not addressed will be sent to the presenters and addressed later. All attendees are muted and video off until the Q&A. And if you have technical difficulties, try logging out and logging back into the webinar. The webinar is being recorded and will be posted on the IPI website soon after the webinar is over, so that the people who are registered and not here can have a look at the presentation. And now it's time to start with the first speaker. And I already introduced the first speaker, Dr. Stephen Salloway. Can you please start the first presentation?
I want to thank the organizers for the opportunity to speak to you today about emerging treatments for Alzheimer's disease. Here are my disclosures. I have worked with a number of companies developing new diagnostic tests and treatments for Alzheimer's disease, and I will be talking about drugs in development, but I have no significant conflicts with the treatments that I'll be discussing today. Let's think about what the main brain changes are in Alzheimer's disease that might be targets for treatment. Alzheimer's involves a process of brain changes over many decades, with the accumulation of abnormal proteins, principal among these amyloid plaques and neurofibrillary tangles made of tau protein, an inflammatory response to help clear the debris, which may become toxic, and many age-related changes in energy metabolism, protein aggregation, vascular biology, and cellular aging that contribute to the breakdown of synapses and neurodegeneration. And all of these are reasonable targets for treatment. We have a small group of drugs, oral agents, that are approved for the treatment of mild, moderate, and severe dementia, which provide some mild benefit, but do not stop the progression of the disease. And what we're looking for is to add to these treatments with disease-modifying therapies applied early that can slow down the disease process and preserve quality of life. And the discussion today will be about where we stand at the moment and where the field is going in developing disease-modifying therapy. A number of treatments have focused on the amyloid beta pathway, the deposition of toxic forms of A beta called A beta 42, the smaller forms of this, the oligomers and the fibrils, and the neuritic or more mature amyloid plaques. And so far, the treatments that have had the greatest progress and chance for success are monoclonal antibodies directed against that cause amyloid lowering of plaques. One of these that got a great deal of attention is called aducanumab. It's a monoclonal antibody that gets into the brain at low concentrations. It binds to the plaques. It stimulates microglia to help break up the plaques and clear them. And in a phase 1b trial, there were promising results with significant amyloid lowering on a PET scan after 1 year of treatment, which was associated with some slowing of cognitive decline. And here you can see that there was a dose-related reduction in amyloid plaques that was very encouraging, and also some slowing of change in cognition. Now, as a result, a number of phase 3 programs are underway or have recently completed that focus on amyloid lowering monoclonal antibodies. And I just wanted to briefly describe the design to you. These are typically 18-month-long studies. They focus on patients with early Alzheimer's disease, mild cognitive impairment, and mild dementia, ages around 50 to 85, sometimes up to 90, with a mini mental state score range of 22 to 30. The amyloid confirmation on a PET scan or CSF is required. ApoE testing for the most common risk gene for Alzheimer's is performed. Patients need to have a documented memory impairment. The primary outcome is typically the CDR sum of the boxes, a composite measure of cognition and daily functioning, with other endpoints being the degree of amyloid lowering, other clinical and downstream biomarkers. There's careful review of the MR baseline scan to exclude people with cerebral amyloid angiopathy or other lesions that pose a significant risk. Anticoagulation may or may not be allowed depending on the study. And each of the studies require MRI safety monitoring for management of amyloid-related imaging abnormalities, the most common side effect of this class of drugs. Well, aducanumab went on to have 2 phase 3 trials, which were stopped early after a futility analysis when 50% had received the high dose, suggesting that the drug was unlikely to meet the primary clinical outcomes. However, after the analysis of the full data set was completed, it was determined that one study met the clinical criteria and the other did not. And there was clear amyloid lowering with aducanumab. The most common side effect is what's referred to as ARIA, or amyloid-related imaging abnormalities, which is typically transient and manageable in a clinical trial setting. The main risk factors for this side effect are the dose of the medicine and the number of ApoE4 gene copies the patient has. 75% of the time, the cases are asymptomatic and usually of mild to moderate radiographic severity, but there can be symptoms of headache, dizziness, unsteadiness, confusion, and visual disturbance. And there are a small number of more serious cases which resemble a syndrome called cerebral amyloid angiopathy related inflammation. This is what ARIA looks like on an MRI scan. You can see a patient before treatment, and then after a single dose of an amyloid-lowering monoclonal antibody, there is these white areas you see in this case in the right hemisphere. The medicine was held. There were no symptoms despite the radiographic change. And after 10 weeks, the symptoms resolved. The MRI changes resolved, and the patient was able to go back on a lower dose of the medication. Another antibody that lowers amyloid in clinical development is called donanemab. It's made by Lilly. It's given intravenously once a month, and a phase 2 trial was completed, which also showed in early Alzheimer's disease. And these were patients, one innovation here, who only had a moderate degree of tau buildup on a tau PET scan. And this study showed significant amyloid lowering. And once amyloid got below the cutoff considered to be positive for Alzheimer's, the medication was stopped. And the study also showed a slowing of decline on a composite measure of cognition and daily functioning, so encouraging results. And you can see here the degree of amyloid lowering with donanemab, the clinical benefit, and also the effect on a plasma marker of phospho-tau 217, which could be evidence of target engagement and perhaps of treatment response. Now, recently, lecanemab, being made by Eisai and Biogen, is another amyloid-lowering antibody that targets soluble amyloid species, protofibrils and oligomers. It also lowers amyloid plaques. And this study recently completed a phase 3 trial. And that trial showed a slowing of cognitive decline on the primary outcome, the CDR sum of the boxes, which was a mild degree of slowing, which was consistent across other clinical measures, and also showed substantial amyloid lowering, where a large percentage of those treated got below the cutoff considered positive for Alzheimer's disease. So now we have 3 drugs in this class who have shown clear amyloid lowering, and also some evidence of clinical benefit. So there are some important questions we need to answer as a field. How much plaque lowering is required for a clinical benefit? How quickly should the plaque be lowered? How safe and effective is this approach? How meaningful are these outcomes, and should they be covered by insurance companies? When can treatment be stopped? and what monitoring is required, and what combination approaches are most likely to enhance the clinical benefit. There is benefit here, but we need to do more to slow down the disease process and preserve quality of life. Now, it could be that treatments like lecanemab and perhaps donanemab, which we'll read out next spring, will become approved by regulatory authorities and may also be covered by insurance companies like the Center for Medicare Services. So we need to think about how we would roll out these treatments in clinical practice. Well, the first thing would be careful patient selection in line with the phase 3 trials. And that would mean early Alzheimer's disease with amyloid confirmation, careful review of the screening MRI to exclude people who may have a more serious reaction, and testing for the ApoE gene. Treatment should be administered by a knowledgeable provider and a treatment team. It's very important to have risk-benefit discussions with the patient and family. These are medications given by infusion currently, and so an infusion center that's experienced at administering them is important. And all of these drugs require regular MRI safety monitoring with a provider and a radiologist who are trained to detect and manage ARIA. We want to detect it early and keep it from becoming more serious. Now, another important advance in the Alzheimer's field are blood tests to detect brain changes with Alzheimer's disease. And there are two types that have really gotten quite advanced, and some have already come into the clinic. One is a ratio of A beta 42, an amyloid ratio, A beta 42 to 40. Another is with p-tau 217 phospho-tau. The two can be combined. They have very good correlation with brain amyloid. They're going to be more economical and more widely available than PET scans or spinal fluid tests. They will help us improve diagnosis in clinical practice, which can be difficult. They'll help us screen patients likely to benefit from the new treatments we've been discussing, and they'll allow us to intervene earlier and use prevention strategies. I just want to mention, time is limited today, but other approaches that are critical and really fully approaching and having a big impact against Alzheimer's disease. It turns out that a large percentage of dementia risk is modifiable, primarily through lifestyle intervention. And this likely involves physical exercise, Mediterranean-type diet, brain stimulation training, and good heart health. And this began with the finger trial in Finland. It's now being carried on by the US pointer trial and is being done in 6 continents and more than 35 countries around the world. So we want to lower the risk for Alzheimer's disease through to promote brain health. We also, because we can detect Alzheimer changes early before there are symptoms, I said this goes, the changes in the brain go on over decades, we can intervene earlier. And this is an example of a prevention trial that began at our site. I'm showing you Dave and Rosalind Kalberer, he was the first patient to receive lecanemab, which I just discussed with you, which was tested for mild Alzheimer's. In this case, we're testing it for prevention. He is cognitively normal in his 60s, but has an increased genetic risk for Alzheimer's and already has a buildup of amyloid plaques on his PET scan. And he's taking this medicine to lower the amyloid plaque buildup and delay or prevent the onset of the memory loss. So we think targeting amyloid will have its biggest impact when introduced earlier in the course of the disease. So where are we going as a field? I think future treatments for Alzheimer's will require combination therapy, which will involve healthy lifestyle to promote brain health, amyloid lowering, agents targeting tau, anti-inflammatory agents, agents that protect the brain and slow down the cellular changes of aging. So I'm very hopeful that we've entered a new era for the modern and molecular diagnosis for Alzheimer's disease that will have important payoffs for patients. Thank you.
Sorry. Thank you, Steve, for your very clear presentation on a complicated topic and for sharing the evidence of new drugs, and especially also for taking us with you in the remaining questions. I see that there are no questions yet in the chat, and I would like to encourage you to put the questions in the chat now or as soon as possible. And also during the next presentation, I know that among the public there are many experts, so we are very curious about your questions. And I would like to introduce the next speaker, Edo Richard. I already introduced him in the beginning, and now I have the pleasure to introduce him for his actual talk. And he will focus on the clinical relevance of new drugs. So please, can you show the presentation?
I would like to thank the organization for the invitation to speak at this webinar. I decided to focus on anti-amyloid therapy. I have no disclosures and receive only funding from non-profit funding organizations. Another breakthrough. We've had many. Since 20 years, we've heard that within a few years, we will have an effective treatment against Alzheimer's disease. And in 2021, there was another breakthrough with the conditional approval of aducanumab by the FDA. But this was a controversial decision, based on conflicting results in 2 randomized controlled trials, which were initially prematurely terminated for futility. And an independent advisory panel of the FDA recommended almost unanimously against approval. And the decision was also widely discussed in the lay press, such as here in a national newspaper in my country, the Netherlands. No evidence, therefore approved. And the European Medicines Agency decided not to approve the drug. And very recently, we've had another breakthrough, with the lecanemab results being published. Finally, a truly statistically significant effect in a randomized controlled trial with a monoclonal antibody against amyloid. But is this really a breakthrough? Sarah Ackley from UCSF and colleagues performed a meta-analysis, including 14 randomized controlled trials using an anti-amyloid drug, many of which were monoclonal antibodies. With this solid meta-analysis, they showed that many drugs were effective in removing amyloid from the brain, as appreciated from repeated PET scans. However, the pooled analysis, from which you can see the results here, shows that in spite of successful removal of amyloid load in the brain, there were no cognitive benefits. And even for the subgroups of monoclonal antibodies only, there was no effect. And I think this clearly illustrates that change on an amyloid PET scan cannot be considered as a surrogate outcome for clinical effectiveness. So how do we understand these disappointing results in the light of the amyloid cascade hypothesis? The cascade has always been a very strong metaphor. It implies a unidirectional process with each step always followed by the next step, with an inevitable final result of dementia. But this is a hypothesis. What if the hypothesis is partly wrong? We already know from large autopsy studies since the 80s and 90s that the relation between cerebral amyloid and cognition in old age is poor. So the disappointing results from the randomized controlled trials may not have come as a major surprise to some of you. And in this context, a report on extended follow-up of one of the earliest anti-amyloid trials is of major interest. Some of the participants in this early trial came to autopsy up to 14 years after they entered the trial. And no amyloid or CSF markers were performed at baseline in these patients, but all had a clinical diagnosis of Alzheimer's disease. And remarkably, in these patients, no amyloid plaques were present at autopsy, but only amyloid angiopathy was observed. But those patients who came to autopsy all had advanced dementia in spite of persistent absence of amyloid plaques in the brain. And of course, we don't know what the disease course would have been like without the treatment. But I think this clearly suggests that complete and persistent removal of amyloid from the brain parenchyma may not prevent further cognitive decline. In parallel to Eckley's meta-analysis, we performed a Bayesian meta-analysis, using all published randomized controlled trials of sufficient size and quality using the ADAS-Cog for comparability. And 6 randomized controlled trials could be included. And why a Bayesian approach? Well, in a frequentist analysis, rejection of the null hypothesis is straightforward in case of a p-value below 0.05. But it does not provide a reliable metric of the probability of the null hypothesis being true in case the p-value is higher than 0.05. And this is what a Bayesian approach can add. And in addition, a Bayesian meta-analysis uses the post-test odds after each trial as new pre-test odds before you enter the next trial, because evidence accumulates over time. And this is particularly relevant when all trials you are studying have a very small effect estimate or are neutral. And using this approach, we found a base factor of 10, which is indicative of strong evidence of the absence of an effect. And in fact, we calculated a hypothetical new trial, what this should look like. And this signal is so strong that only a new trial, including 100,000 participants, lasting for 3 years with completely stopping the disease, could bring the available body of evidence back to equipoise. And of course, we aim to update this meta-analysis with the newly published aducanumab and lecanemab trial results shortly. But this leaves us with the question, why are all these trials not effective? And typically several explanations are suggested after each trial. First of all, the patient's disease may have been too advanced, and patients earlier in the disease could have been included. But this obviously raises major ethical concerns, knowing that many older persons with pathological amyloid in the brain will never develop dementia. And then often it's suggested that the wrong patients were included. They were too old, or they had too many comorbidities, or their risk of decline was not high enough. However, even in autosomal dominantly inherited Alzheimer's disease, in a pre or early symptomatic phase, no effect of anti-amyloid drugs was found after up to 4 years in randomized controlled trials. Or often heard the outcome measure was not sensitive enough. Well, this may be an argument for a phase 2 trial, but I would argue the opposite for a phase 3 trial. It's a major pitfall. We need clinically meaningful outcomes, not statistically significant differences on very sensitive outcome measures. Or the wrong target protein. Surely all anti-amyloid drugs have slightly different mechanisms of action, targeting different protein forms, but they all aim for the same. And they are evaluated by the same PET scan as surrogate outcome, and they follow the same hypothesis. Or the null hypothesis may actually be true. And strangely enough, almost never does this possibility seem to be seriously considered, even after the accumulative number of null effects in trials. But in fact, at this moment, it may be the most plausible explanation. So let's take a closer look at the lecanemab trial results. This trial, meticulously performed, reports a consistent statistically significant effect across all measures of cognition, primary and secondary, and an instrumental activity of daily living scale. And moreover, target engagement was shown, like in many other anti-amyloid drugs. The PET scan improved. But of course, the burning question here is whether the reported effects are clinically relevant. And there's an ongoing debate about the minimally clinically important difference on these scales. And the CDR sum of boxes is an 18-point scale. So clearly less than half a point difference over 18 months is very small. And 1.2 ADAS-Cog points is also a very small effect. And arguably, patients and caregivers may not notice these very small differences. So let's have another look at the interpretation and the caveats of this trial. We discussed already the minimally clinically important difference. I think it's also important to realize that these trials and also this trial include highly selected populations. 235 memory clinics recruited 2 years to have 1,800 participants recruited. This is 5 to 6 patients per memory center per year. And moreover, the mean age in this trial was 71, whereas in the regular population, the mean age of diagnosis of dementia is well over 80. So this is important. And as for the adverse events, although a minority of the area H and area E cases were symptomatic, they were common. And there are serious changes, there are serious adverse events with brain changes. And the long-term effects of these adverse events are not well known. And of particular relevance are the apparently innocent infusion-related reactions here, which were much more common in the intervention group than the control group. And this may in fact have led to functional deblinding, and given the nature of the primary outcome, which is interview-based, this may have affected the outcome. And finally, this positive trial does not allow us to ignore the previous 15 trials, which were all neutral. And these trials are often labeled as failed trials. But I would like to contend that they failed. They were carefully performed randomized controlled trials, meticulously analyzed. They just showed neutral effects. So let's take stock and balance the hopes of new effective treatments against the reality of the current trial results and the major implementation challenges. We have a small effect in a single trial, and I already discussed the questionable clinical relevance. And generally, a second trial confirming such an effect is required. At least this is better than nothing. This is often heard, but I think this is arguably not the case when you have drugs which are very expensive and potentially harmful. It provides hope, of course, and this is urgently needed in the Alzheimer field. But we have to be careful not to provide false hope to the millions of people suffering from this disease. And on the other hand, we have more than 50 neutral trials. The costs of this type of treatment will be astronomical when implemented. And the burden on healthcare systems will be major, far beyond the capacity of even most high-income countries. And this includes the logistical challenges with respect to PET scans, frequent MRIs, 2 weekly infusions, and the safety concerns, which are real and cannot be ignored. And finally, we need to engage in a discussion on willingness to pay in relation to clinical benefit. And this discussion should go beyond Alzheimer's disease, because implementing an extremely expensive treatment to the millions of potentially eligible patients inevitably means that other treatments in other fields of medicine cannot be given. So what are the future directions? I think with the dementia research community, we need to determine the minimally clinically important difference. And what are outcome measures that actually matter to patients and caregivers? And I think we should reconsider the call for earlier, even pre-symptomatic treatments. These drugs are not harmless, and we would end up treating many patients or persons who would never develop dementia. And we may need to revisit the amyloid cascade hypothesis and target different mechanisms as well. And we have the responsibility to take a global perspective and also focus on developments of affordable interventions that can be provided outside high-income countries. So the take-home messages. First of all, anti-amyloid drugs work, they remove amyloid from the brain, but so far do not really help. Unfortunately, also lecanemab cannot be considered a game changer. And the dawn of a new era, as some have proclaimed, is more based on wishful thinking than on solid appraisal of the full body of evidence of anti-amyloid therapy available, unfortunately. I think Bayesian thinking is essential to avoid type 1 errors and overinterpretation of a single positive randomized controlled trial. I think earlier treatment may expose many who may never develop dementia. And finally, possibly other mechanisms than amyloid may be targeted in the future. I'd like to acknowledge a few people for this preparation of this presentation. My colleagues from the Netherlands, Pim van Gol, Melina den Brok, and Erik Mol van Charante, and particularly also Professor Carol Brain from Cambridge University in the UK. I'd like to thank you for your attention.
Thank you very much, Edo, for your excellent talk and for raising the question of the clinical relevance. So it's so complicated for new drugs to be accepted and acceptable for everyone. It's not only about statistical significance, but also about clinical relevance. And I think together with the other talk, you gave a great overview of the problems in novel drugs. And now I would like to give the floor to you, to the audience, to all the participants, and I will start with the chats. And I saw one message in the chat of Bill Reifman. Yes, he is the former president of IPA, and his question is, and it's a question to Steve, how would you define a clinical meaningful benefit in MCI or mild dementia?
Well, thanks so much for including me. Can you hear me okay?
Yes.
Well, I think that the audience has heard two different views of the same recent data, although I think Dr. Richard focused more on the prior data, which was clearly negative or neutral, as he said. The strongest data we have so far is from lecanemab, which showed a mild benefit across numerous measures, clear amyloid lowering. And the goal, these are patients with early stage disease. Actually, to state that the CDR is an 18-point scale is true, but these patients are more in the 2-point range, 2.5 range of the scale. So it's a 0.45 change or 4.9 change within that 2.5 point range. So it makes it a different magnitude. The goal really is to preserve quality of life and to delay progression into later stages where there's greater disability, greater cost, and greater dependence. And I think that these drugs, lecanemab, what we saw from phase 2 with donanemab, what we saw in the EMERGE trial with aducanumab, all provide some degree of clinical benefit, which help patients, those that respond, stay in a milder stage longer. Not every patient responds, but I have had a lot of experience. I've treated 100 people with aducanumab, some for up to 7 years. And a number of them, surprising number of them, stayed in a milder stage considerably longer than expected. There are others I felt that didn't respond at all, but there were responders. And
the families noticed that, they did well in testing, and our staff noticed that. So those are the clear responders. Those that have a mild benefit, which is, I think Dr. Richard mentioned, might be hard to appreciate, but still if they could maintain their functioning longer, and the functional scales did show a benefit with lecanemab, that has value. And clearly there's evidence of amyloid lowering, and those that had the greatest degree of amyloid lowering had the best benefit.
Thank you. I want to stress that here the audience is are the ones who pose questions. So it's a difference from a debate. I can ask now Edo to respond. He might respond later if you want, but first I want to address the questions of the audience. And the next question is a question by Sudhir Kumar. She said very insightful talks. If not the amyloid hypothesis, what are the most widely believed specific postulates of Alzheimer's disease pathogenesis, which researchers are working on across the world from a treatment point of view other than inflammatory mechanisms? Who can I give the floor, Steve or Edo? Steve?
Sure. Well, I think that Edo and I agree that we should target as many plausible mechanisms as possible. Alzheimer's is a complex disease. I don't think there's any debate that amyloid pathology begins early, 10 to 20 years before cognitive impairment. That's followed by tau pathology that includes inflammation. And then there are many neuronal changes of aging in terms of processing proteins, programmed cell death, mitochondrial changes that are all vascular changes, other comorbidities, other proteinopathies, synuclein, TDP-43 that contribute to cognitive impairment. And all of those that can reasonably be targeted should be. And I think Alzheimer's disease is going to require a combination of treatments. I don't think it's either or, do we focus on amyloid or something else? I think we focus on what the patient has and what the majority of patients have, and try to target those in meaningful ways and starting it early to avoid it's really the disability of Alzheimer's that's so, that people fear the most.
Thank you. Another question related to this is that lecanemab showed, it's a question from Jean-Georges, he is director of Alzheimer Europe. And his question is that lecanemab has positive effect also on activities of daily living and quality of life. Would those be clinical relevance from CDR-SB? Edo?
Yeah, I think this is an excellent point that Jean-Georges makes. And I saw another question in the chat about neuropsychiatric symptoms. The major burden for patients and particularly for caregivers is not so much the cognitive impairment. It's mostly the behavioral problems that cause the major burden for caregivers. So I think activities of daily living and quality of life are actually extremely important outcomes. I would argue that perhaps we should use functioning as a primary outcome in our in many of our trials in the future. And it's true, and I think it's very impressive that in the lecanemab trial, across the primary and all secondary outcomes, including an instrumental activity of daily living scale, the results were statistically significant. This is a major achievement. It's a well-performed trial. But on all these scales, including the instrumental activities of daily living, the effect size is very, very small and arguably not noticeable. And I also think that we really need to take into account that if you try a certain hypothesis 15 or 20 times, you cannot cherry pick and you cannot say, look, hey, now finally we have the proof that this type of drugs work if all the other drugs didn't work. And of course, lecanemab has a slightly different mechanism of action, as I said. So it may be the drug that's more effective than other drugs. but it still comes down to the fact that persistent removal of amyloid from the brain in all the trials before was not accompanied by clinical benefit. So that's why I think we should revisit the hypothesis altogether. But the fact that there was also a small effect on instrumental activities of daily living, I would say a compliment to the researchers that they used this scale. And this could be considered as encouraging to use this kind of outcomes in future trials as well, maybe as primary outcome.
So I agree, there was a mild benefit. I don't think we agree that the benefit is small. There was a mild benefit on the activities of daily living. They also had a quality of life measure that was presented that also showed a positive benefit as well. I think the main reason, and there's a lot of debate in the field right now, we need more data, but the main reason why the earlier trials didn't work was had to do with dose and the degree of amyloid lowering. We basically didn't lower amyloid that much, and we weren't, because we were unfamiliar with ARIA, and we were the first to report it, and I probably had the most experience with it. We limited the dose. So in these last 3 trials with donanemab, with lecanemab and aducanumab, higher doses were used, substantial amyloid lowering was obtained, where in some studies, more than half of the patients got below the cutoff of what was considered amyloid positive for Alzheimer's. And those are the trials that showed some evidence of clinical benefit. But there's a debate in the field, how much amyloid lowering do you need, and how likely is that to produce a clinical benefit? We'll see the phase 3 readout from donanemab in the next couple of months, which should have substantial amyloid lowering, and that should provide more information to answer that.
Thank you. Then I move to the question of Paul Logan. Has there been any research to see if exercise can reduce amyloid and tau deposition in the brain?
Well, I think there are many trials targeting lifestyle interventions, such as Steve already showed as well. I've been engaged in several of these very large trials as well. And I think it's promising to look at lifestyle interventions because they're cheap, they're easily implementable, and they may also benefit people, preventing other disease and keeping them more active and mobile. At the same time, I think we have to be extremely modest in what we can expect from this type of interventions. All trials so far were neutral. We performed the Cochrane meta-analysis, and we saw that there may be a very small benefit, again, on cognition, not on other outcome measures. I think some of these studies indeed try to look at amyloid, but none of the studies is really powered for that. And at the same time, the question is, do we have a very good hypothesis why a lifestyle intervention would lower amyloid? And I think without a solid hypothesis, you have to be extremely careful interpreting what you see. In the anti-amyloid drugs, there's a very clear hypothesis. The drugs remove amyloid from the brain, so it makes sense to look at the PET scan, even though I personally think it doesn't contribute if you want to say something about cognition. This can be appreciated from Ackley's meta-analysis. But I think using a PET scan in a lifestyle intervention would not be my first choice of a design of trial. I would say do a very large trial and use a clinical outcome.
So I think all of us really need to pursue a healthy lifestyle to promote heart and brain health. This is a good approach. And I don't know what effect it will have on amyloid load in the brain. We are doing that in the US Pointer trial. Half of the patients will have amyloid PET and tau PET and MRI, and we'll see. I don't really know. I don't have a big, like Ido says about a hypothesis. I think there are beneficial effects in preventing stroke and heart disease. And I don't know if that will translate into some type of amyloid or tau change. I really can't tell yet.
Thank you. I will move to a next question from Mukitoval Adinsky, and it's on exercise. Most recent exercise references address tau and amyloid plasma concentration. and the feasibility and preliminary effects of exercise intervention on plasma biomarkers. So can you tell, are you aware of these results, and can you tell us more about it?
Are you aware of that?
I'm not aware of it. No.
I'm not aware of it, but I am aware. One thing I'm really excited about, I'm at a meeting right now where we're talking about this real time, is the effect of these, just as an example, of the amyloid lowering drugs on plasma tau, plasma p-tau. And that after a certain degree of amyloid lowering, there may be a p-tau change, which may be a marker of target engagement and perhaps an outcome measure. And so we'll see if that proves out over time, but that'd be great to have. So we can see, are we on target? Are we likely to get a clinical benefit or not? I haven't seen it with exercise. Again, I think the effect is going to be smaller, so I don't know what effect that would have on plasma markers of amyloid or tau.
Thank you, and also thank you for the question and giving this new information on ongoing or on studies that are already published. The next question is from Mohammed Singh. Thank you for the wonderful presentations. Are any trials going on for patients with severe dementia?
It's not my field of expertise, trials of severe dementia. I think there would be other major ethical concerns in trying to slow down the progression of clinical symptoms in people with advanced dementia. I think we would have to engage in a very serious ethical discussion about potential adverse events and what can still be expected that actually benefits patients.
Yeah, I think, again, obviously there's a great need for care and better treatment and better clinical trials for later stage disease. It's very heterogeneous and hard to do. I'm aware of one tau antibody trial for moderate Alzheimer's disease. I'm also aware of another trial of cannabis for terminal agitation. It's more a palliative care approach for patients with very late stage dementia. I think there are also some behavioral trials and medication trials to treat some of the behavioral symptoms of late stage dementia, but addressing the fundamental components of the disease in later stages has not been a key area of focus recently.
Thank you. The next question is from Maria Lapis. Would there be any safety issues for combining anti-amyloid therapy with non-invasive brain stimulation, such as transcranial magnetic stimulation?
Well, that's a great question. I think we're going to need combination treatments. I think and I agree that this effect is small, and so we need to build on it. We want to make it more substantial, either through this treatment with combination with others or other treatments that are more effective. There's nothing prohibitive about that proposal. It obviously hasn't been tested. It's now complicated because you have two completely different treatments. But I think we need to think outside the box of how we can combine treatments. Certainly, there are a number of initiatives to combine amyloid and tau treatments. We're testing a drug that's approved for HIV that has an effect on senescent-related inflammation. We're doing it because we have some patients on background therapy on amyloid-lowering drugs. It's not intentionally designed that way, but we'll get some safety information. Obviously, as you increase the complexity of a trial, then you have to carefully evaluate the safety and efficacy. It makes it more complicated.
Thank you. And I have two more questions. I see three more questions. And I choose for the question, so we can only deal with one more question, I think, before the end of this webinar. the question of Gabriel Martinez is, do we have the risk of having combined outcomes as a main outcome, like behavior combined with functionality, cognition? If this happens, we will not know what we are treating. I think this is a very intriguing question.
I think it is an intriguing question. It also covers slightly the next question of Chevi Ben Chaupara, that I think eventually all the effects will translate into functioning. So the idea of measuring functioning to me is very appealing, because that's what matters to patients, remaining independent, but it's also what matters to caregivers, because also neuropsychiatric symptoms will affect functioning. I think we should very clearly stick to the idea of having one primary outcome and have a proper sample size calculation with a good hypothesis of an to be expected effect size, which is minimally clinically important difference. There's not something in principle against combining things if you pre-define it like that. If you define them as co-primary outcome, 3 different ones, it means you need to have a statistically significant effect on all 3 outcomes to decide that your trial is positive. So if you decide to take 3 co-primary outcomes, do a proper sample size calculation and find an effect on one, you have not shown benefit and you cannot reject the null hypothesis. So I think it's an extremely important question to think about what the most appropriate and clinically relevant outcome is. Combining outcomes is challenging, and I would argue to choose the most relevant one as primary outcome and take the other ones as most important secondary outcomes. And they will show a different level of evidence, but can still be highly informative.
Thank you. And this is an excellent summary of the information both of you gave. And I close the Q&A now. And I want to thank, first of all, the speakers very much, and the organizers, Jennifer and Christian from the IPA office, and the audience, because you had excellent questions. You had so many questions, and well, we nearly dealt with all of them. I think there is only one remaining question, but we will check it later. So thank you so much. And we will send you an evaluation form, and we highly appreciate if you fill it in and give suggestions for new topics, because IPA want to address the interest of its membership. And in April, there will be our next webinar, and we submitted a webinar for the IPA conference to have a live webinar, and we are expecting the answer of the jury of the IPA conference. Thank you so much for making this a very thoughtful, great meeting. Thank you.
Thank you.
Bye-bye, everybody.
Bye.